Plus, most probably we'll talk about the newer studies which are coming out. The FLORA-2 recently just got published in the Journal of Medicine. Now they're combining chemotherapy with targeted therapy. Even if there's a target, you combine the two together, and that's what you get the maximum benefit for. So poor performance status, I always give chemotherapy. If the patient is fit sometimes, not very bad, and doing very well, sometimes I wait in these patients for the genomics to come back, especially EGFR, ALK if they've been sent. But if you're waiting for 4 to 6 weeks for a full panel, I like to give one cycle of chemotherapy.
Yeah.
What about locally? Do we have any NGS available locally that has a slightly kind of good turnover time or?
No, I don't think so. It's all sent out tests.
Yeah. So, Samit, how you deal with scanty lung biopsy specimen? Because this is another challenge which we see most of the time in our patients, that the sample was small and they have done few of the investigations and further not is not possible.
It totally depends from one case to another. Like in this case, you have got a supraclavicular lymph node, luckily. So I don't know what's the size of that supraclavicular. If it's a good size lymph node, you can also get a true cut biopsy from that. Like my colleague just said, that with the biopsy, you were staging as well as diagnosing. So you have that sample, but things get really difficult if it's just, again, in this case, there's iliac blade mass, but it's not a mass. It's a small lesion, difficult to be targeted. You just get aspirate, and again, you don't have any answers for the patient.
Yeah.
So for this patient, supraclavicular lymph node would be my next target, if in case we need a biopsy and it's not good.
So the treatment options.
It's very simple. I believe Keynote 189, Leela Gandhi's landmark study, which changed the way we manage these patients. It's pemetrexed, carboplatin with pembro. Even in the PDL negative patients, the hazard ratio was 0.5, as low as in the patients who were PDL strongly positive. So I always offer my patients pembro plus pemetrexed plus carbo, and pembro, obviously, if they can afford it. That's my choice.
Which pembro?
Which pembro? Yeah. Well, there are, I believe, 2 registered pembros available now. Yeah. One is from, in fact, the third one is also coming out. So there are 3.
The Russian one?
One is the BioCAD. Then another one is the Beacon Pharma from Himal. And the third is from Oncovent from Ziska. They're 2 from Bangladesh. So I only use the registered drugs now.
Yeah.
I've had used these smuggled drugs in the market, but I don't think so these drugs work. So rather than wasting money on these unregistered drugs in the market, I tell them, if you want to use pembro, use the registered one. If you don't have the money, or if you don't have that much, because those registered drugs are more expensive, I said, don't use immunotherapy, just go. See, in PDL1 negative, obviously the curves showed benefit. But in the third world country, you really have to be sure what you're doing. So I really don't push in PDL1 0, though the standard of care is to give these patients pembro, because the original Keynote 189 study showed hazard ratio reduction of 0.5, the 50% decrement of death in these patients if they were given pembro with chemotherapy upfront. So I really don't know how to interpret this data and how to offer it to my patient in a resource-limited setting where money is such an issue, drugs are such an issue. So I don't know. But if it's positive, I push for pembro a lot. If it's negative, I give them option. If they want it, they take it. If not, I say that's okay. And I always put them on maintenance.
Yeah, we'll come to that. Yeah. So again, I think it's very important to be very clear in this era, is the intent is palliative or radical. And first line of choice of treatment, which we already discussed, chemotherapy or combination chemo immunotherapy. So we all know that these patients are living longer because of the immunotherapy options available. So making them palliative to begin with is something which is not really encouraged these days, because these have a lot of options available. Dr. Samid, any point do you want to agree on?
I didn't understand your question.
Yeah, so as I'm saying, looking into the metastatic disease, we don't need to be starting with the intent palliative to begin with, because now initially we don't have any treatment options available. But considering this patient has a solitary oligometastatic disease, so what's the intent is? Is that intent is palliative or radical palliation?
For this patient, palliative.
Yeah.
Look, oligometastatic disease is a very broad term, but you need to understand the primary nature of the disease. With a T3N3 disease, I would not go with, like, I know what you're talking about, ablate the iliac blade. I won't do this.
Yeah.
Maybe in oligo recurrent settings,
Yeah.
I would consider, but not here. Even if sometimes I'm forced by my medical oncology colleague do something about this iliac blade mass. If there is pain, I would just offer simple 8 gray 1 fraction. That would work very well. I won't go with 20 grain 1 fraction. There is no data to ablate that upfront. It's not a curative case. We know T3 and 3, it's not a curative case.
So yes, I think I would like to add something that in this situation, particularly this patient which has a T3 and N3 disease, giving SABR to a MET at the moment is something which is not advisable. But yes, we know that we have chemoimmunotherapy options available, followed by maintenance treatment. And later down the lane, if the disease remained persistent, of course, and patient had a good performance status and long progression-free survival, that is the time where we can think about radical treatment. And I think at that time, more toward the stereotactic if there is no disease elsewhere rather than 8-gray single. So keeping the constraint and cost issue in mind and the available support options, again, we know that in Pakistan, we have to think about a lot of other treatment options which patient can afford. And there are some immunotherapy drugs which are giving the support program offering to the patients, and depending upon that, we have to select the treatment. So patient...
One thing I just forgot about the chemo, or I forgot in lung, obviously Tecentriq is a very good option, because we have a support program
Yes.
available that is registered, temperature controlled. So for lung, usually my drug to go to is Tecentriq, though the studies are again very controversial. If you look at the Tecentriq studies, the hazard ratio reduction was not as great as in the Pembro studies. So if you want to be a purist, if you want to really get the benefit, then obviously Pembro is the drug to go, but the lack of availability, the cost, all these issues, a lot of times it forces me to use Tecentriq.
Yeah, and in that particular
my
combination.
My simple question for my guidance and the guidance of residents, can you do this Pepsi and Coke with Tecentriq and Keytruda in this scenario? Would you advise?
Well, the studies, the keynote studies, in the Tecentriq studies, the hazard ratio reduction was 0.8, 0.7. So there's a 30%, all the studies. But in Pembro studies, the hazard ratio reduction was very dramatic. It was like 0.5, 50% lesser death rates in the Pembro arms. So if, countries where these drugs are available, cost is not an issue, Pembro is the drug to go to over there because of the dramatic reduction. See, they just published their data of the first trial in which patients, like 10 years ago, they ran the first trial. There are 25% of the patients who were stage 4, they're still alive on Pembro. And they believe that these patients are cured of their metastatic lung cancer disease. See, we don't have this strong data for Tecentriq, atezolizumab.
Yes.
So the data is very, very strong for Pembro, but we have our own logistic issues over here.
Yeah, I completely agree and advocate you in this situation. The primary preferred option is Pembro, but again, the limitation. So this patient was on treatment, and after 1 year of maintenance treatment remained symptomatically well with good performance status. So a routine response assessment PET scan was performed.
So based on this, there appears to be a new lesion in the vertebral body, which is also hypermetabolic. And then you've got this right supraclavicular nodal thing, and what looks to be a hepatic metastatic focus as well in the lower image. So comparatively, there is progression, there are new sites of disease, and there's visceral now as well.
Yeah. So PET-CT report showed that development of bilateral supraclavicular left upper paratracheal abdominal nodes, as well, and a new development of osseous lesion in concerning for disease progression, interval development of hypermetabolic left parietal lobe noted, for which an MRI brain was requested, and the primary mass was relatively decreased in size and avidity. So this is the MRI brain, which actually showed multiple lesions in the right cerebellum with some visogenic edema. Intent, again, as we have discussed, will remain with the palliative. The treatment option, would you like to change the systemic treatment, or you would like to address the brain first, and we'll take one by one? Yeah. Sameer, I would like to have a comment on a brain radiotherapy first, and then we'll go through the systemic options.
Uh, no stereotactic radiosurgery in this case. It's not an isolated brain recurrence. It's a progressive disease all over the body. So no stereotactic radiotherapy for this patient. I would go with whole brain radiotherapy if the patient is ECOG 0 and 1 only, not even for ECOG 2.
Yeah, I would say like in this time point where the patient are young and asymptomatic, and where you can easily do the stereotactic radiation followed by change in systemic treatment, that could be a fair option. We understand our limitations sometimes where the further treatment options patient cannot afford or with the poor performance status. So it's a debate actually.
Actually, I get
because-
the point. It's very tempting. It's a very easily doable stereotactic radiotherapy, but it was the same with the iliac blade lesion. That was a piece of cake for a stereotactic radiation for SABR, I would say. But not every cake has to be eaten.
Yeah.
So I know this patient is not going to die of the brain disease only. So I would not waste his resources and my resources on stereotactic. That might take, but again, people have different views that the young age of the patient and there would be lesser toxicity than whole
Yes.
brain radiotherapy.
Main challenge of whole brain radiotherapy, as Munib, you can contribute.
This is Dr. Munib, radiation oncologist at Shaukat Khanum. So this is again the dilemma is about the whole brain radiotherapy versus this SRS. If we talk about the developed countries, the shift is totally towards the radiosurgery right now because of the availability of the advanced treatment. I would rather like case-based scenario you have to discuss. I agree with Dr. Samit. The thing is that for this patient, if he has systemic treatment available,
Yeah.
I would rather opt for SRS because now it is volume-based and we can save this patient if this is the first time recurrence. I think the guidelines still suggest about the disease-specific GPA. I would rather first calculate that. If the survival is more than 6 months, I would go for SRS first. That's my comment.
So I think there is no right and wrong answers, but again, yes, we have to look for multiple other factors depending upon what the disease-free survival this patient had. So he has a very good 1.5 year post chemoimmunotherapy, was on maintenance, developed this. So Dr. Kamran, now your role of NGS at this time. Yeah, what about that?
It should be done ideally, and it can be tried on the blood. You can do heme panel, send
Important message.
and look at for any newer mutation. If there are no new mutations, then basically, obviously, immunotherapy has to be stopped. Patient is progressing on immunotherapy. That's very, very important. Sometimes people like to continue immunotherapy and add a chemotherapy to it. So once there is progression on immunotherapy, it's not pseudo progression, it's clear-cut progression. You stop immunotherapy. And obviously, we move on to the second line, usually docetaxel-based chemotherapy.
Yeah, we'll come to that also. So we have Dr. Mariam, the pathologist, consultant pathologist with us. I just want to know about some detail. Can we have a just mic for her? So what test we can have on a blood NGS? This is something which is also very difficult to interpret for someone that like PDL1. Can we have that?
Now, the PDL1 testing that is FDA approved, that is approved for the tissue testing. So that is done on tissue. Again, the problem with the tissue is that we already have a very small biopsy for the diagnostic purposes. And the problem with the paraffin embedded blocks is that you make first cut, for example, you get a 5 millimeter tissue, and out of that 5 millimeter tissue, there is a 3 millimeter of a tumor. You make a first cut for the diagnosis. You make a second cut for the diagnostic immunohistochemistry. You make a third cut for ruling out neuroendocrine or other markers. So initially you made a 2-3 cuts, and that 3 millimeter has already gone to 2 millimeter or 1.5 millimeter. Now, recommended is PDL1. What the protocol is that we already cut, just while we are cutting for the diagnostic purposes, we cut an extra for the PDL1 and extra for the ALK, fish ALK. So that's how we try to save our tissue. Then this ended for EGFR. Now for EGFR, a much more tissue is available. So sometimes what happens is by the time we finish by the diagnostics, PDL1 can be performed, ALK can be performed, but there's not enough tissue for EGFR left. So obviously we do recommend that NGS has a role in this because it covers all other marker except PDL1 because PDL1 is more reliable on the tissue.
Yeah, thank you. So patient was planned for stereotactic radiotherapy. Again, at the time of diagnosis, and the MRI showed 4 lesions, but when we did the MRI SRS protocol, it shows the total lesions up to 10 brain metastasis. I think again, the valid option coming in from Dr. Sami, that what is the time now, changing it to whole brain RT or continuing with the stereotactic?
If you have planned it for steroid, 10 brain mets should not stop your intent. It was my intent of offering whole brain.
Yeah.
If I have started it, 10 brain mets is not an issue.
Yeah.
Continue with SRS then.
So we did that, and actually we did plan stereotactic radiation for all 10 metastases, and you can see on these axial and the sagittal images that the normal brain can was spared, because again the important message or a thing I would like to highlight is it's also very important the volume of the brain metastases, like they were small and they were of this volume that we can incorporate into the single fraction, because we all know that we have a dose evaluation form, and according to that we did plan the patient. So patient was planned and delivered. So again, the question is now switch to the second line treatment. I think the important discussion at the time with the patient is the prognosis, because that I think it's very important to be aware of taking informed consent and discussion with the patient, what the reality is, where we are, what are the options. Yes, Dr. Khanum.
Yeah, obviously the disease is progressing. The median survival for metastatic lung cancer is like 1.5 years, 2 years at the most. Patient has already lived one and a half year. So we're pretty much end of the road. Docetaxel plus even if you add Cyramza, ramucirumab, at the most it'll add 6 months, maybe 1 year at the most, that the patient is very lucky. So, it's very important. Yeah, it's very true that at this time, the prognosis, the family has to be counseled, the patient has to be counseled, what we expect from this treatment.
Yeah.
And what is now the quality, the palliation is almost ending now, and the quality of life, the pain management, all these, the palliative care really kicks in at this time of they need to work very closely with the patient.
Yeah, I think to involving the palliative team as well at this time is very important, because down the lane, when the performance status decline, it is very difficult for the patient and the family to understand that we are talking about supportive management. So this is the best time to start discussing the options with the patient. Dr. Kamran, I was just want to highlight one of the point in your experience about circulating DNAs, which is coming in at the moment, that you should have at a baseline. And are you following these patients frequently? How frequent are you doing? I know.
Circulating DNA, I don't think so. People are not getting NGS, so what to talk about ctDNA? It's expensive technology. I don't know how much integrated that is in lung. I know in colon cancer, in other malignancies, there's a lot of work done. In early stage colon cancer, ctDNA has really become the standard. In hematological malignancies, MRD has become a really standard of care. But I don't think so. Maybe in early stage disease, in neoadjuvant setting, they're looking at circulating DNAs and deciding if the numbers are going up, change of therapy. But I believe it's in infancy in thoracic oncology, and they really don't know whether. See, another question with circulating DNA is if you pick it up earlier on, would doing intervention affect the outcomes? The overall survival improves or not, right? That's another question. You pick it up earlier on, but whether it will help the patient in long term or not. So there's a lot of questions, and I believe trials, longer follow-up will prove that earlier intervention helps these patients or it does not.
Yeah, completely agree. So this sum up the case 1, and I think we move to a second question. And if there is any question from the audience, happy to take that. And then otherwise we'll switch to case number 2. Okay. So case 2 is again a 58 years old female housewife, non-smoker, non-asthmatic, presented with pain in left chest for last 9 months, associated with 6 kg weight loss, occasional episodes of shortness of breath. The performance status is 1. From the residents, I would like anyone to comment on, like, again, the differentials remain the same, how you normally investigate these patients? Anyone from the resident? What the first test to perform or basic investigations? Anushi?
For this patient, we can get a CT, given her history, and she has weight loss, would suggest actually a malignancy, possibly. So we can get a CT to rule out a malignancy versus tuberculosis in our region of the world. Yeah.
Yeah, so I think the basic also again start from chest X-ray and then CT scan, because these patients are presenting to emergencies where all the treatment options are available. So this is a CT thorax. Dr. Amna, if you want to just comment on. This is actually the lung window. I haven't put the mediastinal window for you.
So you can see a dominant mass in the left upper lobe. And yes, the margins are lobulated. I do see some tiny densities, subpleural. It's a single slice, so it's hard to say.
Yeah.
There is concern. We do need to biopsy this thing and see what's going on. And it depends. PET CT after
later down the-
biopsy,
yeah.
not right now.
Yeah.
What if it's TB?
But I think that
Yeah.
in early stage cancers, if we do PET CT scan, that help us see the mediastinum as well. Because if we are going for biopsy, then doing PET before biopsy will help, because otherwise that will, if we see mediastinal nodes on PET CT, then we'll have to do another procedure. So I think PET CT in early stage cancer, doing PET CT early will help us stage the cancer.
Yeah.
That's actually an excellent debate.
Yeah.
And again, it's resource limitation, which I think in the long run, it does save money to biopsy to begin with, but the scan being expensive, sometimes if I had my way, I would say everyone should have a PET CT upfront. CT does help, but what a PET CT reveals is certainly more.
I think
I actually agree with Dr. Adnan. Lung
Yes.
cancer is not our disease. So
Yeah.
we follow the West totally. So solitary pulmonary nodules and things like that, they are followed up in West. And when you have a suspected malignancy, they do get the PET CT upfront in NHS.
Yes.
If you are seeing that this can be malignancy and it can be treated with SABR, you do get PET CT for the same reason that Dr. Adnan said.
Dr. Adnan, I just want you to highlight the importance of screening CT scans, low-dose CT scan, and the clinics, actually, which we don't have integrated clinic available for these patients for screening purposes and then early detection.
Obviously, we don't have that services in Pakistan, but this is something that is started in West, that they're doing low-dose CT scan on all the high-risk patients, so that we can pick up those cancers which are in early stage, and obviously they will have good outcome if they are treated at that stage. So obviously that has a role in patients who are at a high risk in doing low-dose CT scans.
And how difficult is that to convince patient, I think, in terms of Google information, which is available everywhere, that, oh, it's a dose of radiation associated with that, with the CT scan.
But again, as I said, that it is indicated for patients who are at high risk. So trials have shown that they pick up patients at very early stage, and if we see those patients will have good outcomes. Obviously, there is a risk of exposure to radiation, but we don't radiate everyone. We kind of pick patients up who will have a maximum benefit in doing a low-dose CT scan.
Yeah. So this patient, again, it was a peripheral lesion and there were no mediastinal node at that point, but I will later discuss. CT-guided biopsy show moderately differentiated adenocarcinoma acinar pattern. And again, the ALK gene rearrangement was not detected and PDL1 being carried out. I think the very important question, Dr. Mariam, again with you, is there are two PDL1 testing which are available, and sometimes the pathologists are asking us that are you giving a TIZO or Pembro, what you're looking for. But in lung cancer, where both treatment options are available, so how do you differentiate, or what the ideal strategy in these patients?
Yes, just as you said, well, there are actually 4 clones available and 5th is the lab developed one. But in Pakistan at the moment, we just have these 2 available, and SP142 is against atezolizumab and 22C3 is against pembrolizumab. The most recommended one is 22C3 because even we follow the College of American Pathologists proficiency testing in our department, and even they advised us that for the lung carcinomas, you should prefer 22C3 because it has better results. And even in your experience, you must have noticed that SP142 is hardly positive in any lung
In our
cancer
population, yeah.
So 22C3, I've seen some really, really good positivity in lung cancers. And as this is a lung adeno with SNR pattern, here I also like to mention that WHO also wants a pathologist to mention the pattern of the adenocarcinomas because it affects the prognosis. The SNR1 has a better prognosis than the micropapillary or papillary or solid patterns. So that is a subtle prognostic sign as well in the report. Again, because these both clones are expensive to perform, and obviously it depends upon the clinician which therapy they want to try first. So that's why we ask the clinicians that which either you're giving Pembro or Atizo. Based on that, we'd like to perform the PDL1.
Yeah, and Dr. Mariam, just one more question. I think we all agree that sometimes the pathologists give us the report favoring non-small cell lung cancer, and they don't give us the further differentiation. So how to deal with that? Or is there any circulating, like you peripheral blood are available where you can differentiate, or no, we can't?
The primary diagnostic tool remains the biopsy. And if you go through the WHO classification, it does mention non-small cell carcinoma, NOS at the end, but obviously you have to rule out all other things before reaching that point. And unfortunately, as I said earlier, we already have a very small tissue. And by the time we are done with all diagnostic immunomarkers, the tissue that remains is not sufficient for the NGS. Because in NHS, what I found is that if we fail to reach a particular diagnosis and we just label it as a non-small cell carcinoma NOS, they just send it for NGS and they just try to find if there is any targetable mutation identified then. But the problem, when I compare the both systems, the thing again is that we are doing NGS mostly on the tissue specimens. So that's our limitation, that again, not much tissue is available. But if there's a blood NGS available, then I think they just turn it to that. And even if then that's not available, then it just remains non-small cell NOS.
Yeah, thank you. And the key home message, Dr. Adnan, we need more chunky tissues.
So yeah, just to give you an idea, obviously we do the EBUS FNA,
Yeah.
which is a very small sample, and we get cytopathology sample on that as only. But we have started doing FNB as well, fine needle biopsies, which is a slightly different needle in which the end of that needle has got spikes on it. So it gets a good tissue sample. So that hopefully will help in future to get a good sample from those patients.
And what's the difference between TBNA and EBUS?
So TBNA was previously done blindly using the bronchoscopy. EBUS is that we use the ultrasound guidance. So from sample point of view, there's no difference. But this time the needle is slightly different in FNB. It's a serrated, it's a spiked needle, so that will give us good tissue sample when we aspirate. So that
Is that image guidance as well?
What's that? This is ultrasound guidance as well. Yeah.
So, and any other further staging workup? I think we have already highlighted the part that these patients for the primary lung cancer need PET-CT and MRI brain in their staging workup. Again, we know that we have done PDL1 and we have done ALK. The other immunomarkers which are important are EGFR. Better is again the NGS, where we have a detailed panel and multiple mutation check. But if not, again, that is costly. Sometimes you have no tissue available, and then if we have to differentiate, I think that is also one of the main concern is the cost limitation, that if patient, we need to think more about spending the money of the patient in treatment or further investigations, because these also cost about more than $1 million according to the dollar rates. Again, the timing for results we have already discussed, and so the treatment option. So before that, I would just show the PET CT so that we can know and we make up a stage. So the PET CT again confirms the finding, which were the left up lung mass, which are hypermetabolic, and ipsilateral mediastinal lymphadenopathy. So the PET CT report was T4N2M0. So now the treatment options.
So basically T4N2 is 3B, 3C. So 3C goes chemo-RT concurrent. So new adjuvant immunochemotherapy with nivolumab, Keynote 816 trial, right? We give 3 cycles before, no, that's before surgery, sorry. So I believe chemo-RT for 3C, there's no role for surgery for these patients.
I just put that slide and want to highlight the fact that how often are we using in our setup, in your setup, the immunotherapy in a concurrent setting, because now more evidence and data is coming to downstage these patients with chemoimmunotherapy before chemoradiation.
For chemoradiation or before surgery?
Again, that is the N2 disease. I don't know how difficult it is to approach the surgeon in your setup.
No, I don't think so. This patient will be for 3C. Usually, chemo-RT is the way to go. Surgery is not the way to go. If your contralateral nodes involved, or even if N2.
N2 will be the, it depends on whether it's a single station or not.
Yeah.
Exactly. And
The
also,
bulky tumor.
what kind of T4? Look, T4 is a very broad term. We were all thinking of T3 and not or T2 and not, but it came out to be T4. I think it was invading the mediastinum. That's why it was T4.
Yes, it was. It was.
So again, the size of the tumor,
Size and
the
the
number of lymph nodes, the whole chain, it depends. But again, 3C, this is 3C.
Yeah.
So the prognosis remains poor and should be treated accordingly, either with induction followed by radiation or concurrent chemoradiation.
Yeah. So we all know.
Another thing is if you use concurrent chemo-RT, then Pacific trial, then adjuvant
I will ask you
immunotherapy for 1 year. That's not all.
Yeah. So there is no role for the upfront surgery at the moment, that is for sure. And again, the role of radiotherapy, I would say that if a patient is fit and with this good performance status and this radiological finding, the radiotherapy alone is inferior. We need to give a concurrent chemoradiation or to downstage the tumor sometimes, depending upon the feasibility of the treatment planning schedule in your setup, where you downstage the tumor by giving first cycle and then start chemoradiation with the second cycle. How often are you using that indoximide in your setup? What's your practices normally?
We don't have CL lung cases curative often, so we are not using anything often enough. So it's case to case based, but I usually rely on my medical oncologist for the decision of concurrent chemo. If he says he's got something fancy available, then it's fine. Other than that, simple pemetrexate, cisplatin, and we tend to start radiation with the second course of chemotherapy.
Yeah.
The thing is, should not add, if you're doing chemo-RT, should not add immunotherapy. Because it increases the risk of interstitial pneumonitis of the lung. So when it's given in the adjuvant setting after 4 to 6 weeks after finishing radiotherapy, so that radiotherapy is washed off, and then you give adjuvant immunotherapy for a year. So in new adjuvant setting, only immuno is given in a surgical candidate. The 816 trial recently published with nivolumab, this is 3 cycles for surgical candidates who are surgically resectable.
Yeah, so the other important question, Dr. Kamran, I want to highlight is that these patients who we treat with concurrent chemoradiation, towards the end of the treatment, their performance status declined, and they were suffering from a lot of pneumonitis, even with the radical concurrent chemoradiation. So what is the time frame where you start your adjuvant part, and are you looking for any PD-L1 levels to start that, and what options are available?
Showed nivolumab was used as immunotherapy study in FINZI. And in that, the subset analysis, the PD-L1 positive as well as PD-L1 negative benefited equally from this immunotherapy regimen for 1 year. So obviously, I wait for 4 to 6 weeks, see how the patient is doing. If patient is well, we just proceed with the immunotherapy in these patients. Now, again, nivolumab is not available in Pakistan.
That's why I asked.
There are some trials with the trial known as the deterred trial, atezolizumab. They gave atezolizumab for 1 year, and they reported some benefit from it. So we do a lot of cross exchange
We have to.
immunotherapies.
Yeah, and do you stage these patients post-chemo radiation with the baseline restaging CT scans, or you just start the adjuvant treatment?
I believe that it started, but it's good to restage them after 6 weeks, how the lung is,
Yes.
any pneumonitis, any pneumonitis or, if lung is damaged, how good the lung looks. Most of these patients, she's not a smoker, but a lot of these patients are smokers, they have emphysema, a lot of lung changes, then they get radiation in a pretty radical dose, right? Chemo is a radical dose. So again, it's good to get a scan before starting immunotherapy, I believe.
Yeah. And very rarely we do see some surprises with development of the lung nodule in the contralateral lung. So the patient receive concurrent chemoradiation. We normally, the fractionation which we are using is 55 brain, 20 fraction hour setup. And Dr. Sameed, how often are you using 4D CT scan, or what the preferred options, or how difficult is that for the patient to do 4D CT scan?
We are not using 4D CT scans. We are more comfortable with the DIBH. Again, for a CL lung patient holding breath for such long durations, but these patients are quite rare who go on concurrent chemo, and that again 3C. We tend not to use 4D CT scans just because of our institutional experience. Even the patient, he can hold breath for 20 seconds. We find it more convenient and more confident. Even we do the CT scans and you are doing in breath hold. So the target again becomes smaller. We are not concerned here with the volume of target, it's a bigger target. So individual preference with us is DIBH, what we do.
Yeah, and for the trainees as well, we do like the 4D CT scan is something which is, what are your margins in DIBH breath hold technique? Like you are using the larger margins or going with
No. With DIBH, you don't need to use larger margins. And with triggered imaging, you would actually see these lesions moving in or out of PTV, so you can adjust. So
yeah,
smaller
so in
margins are
ideal
enough.
world, it is a 4D CT scan, but we have to again treat this patient depending upon what available options you have, your setup, and how the department is comfortable with. So with the help of 4D CT scan, the tumor delineation becomes a little bit cumbersome, but again, we incorporate the tumor motion in all the phases, then take up to the average and then give a margin. When you are contouring it in all the phases, the point is that before the era of 4D, we used to give bigger margin, 1.5 to 2 centimeter, but now with the help of 4D CT scan, we can give a margin of 0.5. But again, keep that in mind, the setup margins, which are very important. Despite of 4D CT scan, despite of patient immobilization, we do see patient setup errors a lot, and therefore the going beyond or lesser than 0.5 in this time is something which is challenging. So better to go with 0.5 to 1 centimeter. So in this patient, we use cisplatin vinorelbine 4 cycles, and patient tolerated the treatment well. And this is just an axial slice showing the concurrent chemoradiation plan, where we have incorporated the primary tumor, the mediastinal node, incorporated the movement. And here the important thing is the OARs, which are very important not to be neglected, the spinal cord, the contralateral lung, and sometime the brachial plexus if you are going up in the neck as well. Beam arrangement, we normally try to use an ipsilateral 2-arc therapy, but I understand that it is different in different setup wherever the plan is available, or you can achieve your doses to OAR, you can use any plan. So we have actually included the 4D CT scan in our discussion, tumor management and breath hold technique. Nothing is superior or inferior. The main important point to reiterate is the tumor incorporation of the tumor motion. And I think we have summed up the role of concurrent immunotherapy in concurrent chemoradiation era. It's still difficult because these patients are suffering a lot from the symptoms. So to bombard with all, I think the other dilemma would be bombarding these patients with the immunotherapy in the concurrent setting, and then adjuvant. Down the lane, if they progresses, what will be the treatment options? If we have already used the pembro and the durvalumab in the radical setting.
I have a question from Dr. Kamran. With the Pacific trial and durvalumab is not available, would you offer atezolizumab instead?
I said the trial, deterred trial, in which they used atezolizumab for 1 year. Again, with atezolizumab, the hazard ratio reduction with all the lung trials has not been really great. The dramatic reduction we saw with durvalumab. But if you don't have any option available, see, I've asked a lot of experts, world-renowned experts, when I go to meetings, that we only have Tecentriq available in this part of the world. We don't have Pembro at that time. These drugs are not available. What should we do? So a lot of experts say if you don't have anything available, just use whatever is available in immunotherapy. That's what they say. It's PDL1, that's PD1. That's what they say.
Yes, and I think in most of the cancers, we have atezolizumab available in the treatment options, but in some sites where the atezo is not a standard option, but because of the sport program, we have to discuss a transparent discussion with the patient that this is not the standard of care, but yes, it is available. Yeah, Mohsin, go ahead.
So PDL1 testing is required if we are giving chemoimmunotherapy or immunotherapy in neoadjuvant settings? And if yes, then how much score for it?
What's that?
PDL1 score required
No.
if
Again,
using atezolizumab.
no. The study showed that irrespective of the PDL1, just like in the metastatic setting. See, the PDL1 score is one part of the picture. Lot of experts in thoracic oncology believe that PDL1 is not the sole marker which determines the efficacy of immunotherapy. Like in metastatic setting, if you're PDL1 negative, but if you have a TMB, tumor mutational burden, which you get in the NGS, a lot of these patients respond. Dr. Rizvi from Memorial Sloan Kettering has extensively published on that he published a series of patients who were TMB positive and PDL1 negative. And all of them had responses as good as PDL1 strongly positive. So they are working on it. They're trying to find out a marker which really predicts the response to immunotherapy. But in these trials, metastatic, as well as in the adjuvant, as well as in the stage 3C, the efficacy of immunotherapy was irrespective of the PDL1. When they did the subset analysis in these trials, the PDL1 negative benefited as much as the PDL1 positive benefited. Similar is the case in the breast Keynote 522, the neoadjuvant triple negative trial, in which if you look at the subset analysis, the PDL1 negative as well as PDL1 positive benefited equally from the Pembro.
So we have to give chemoimmunotherapy in that case, or immunotherapy?
No, just immuno. In this case, the stage 3C, we'll just give maintenance immunotherapy for a total of 1 year.
Mohsin, we are talking about, I understand your question now. You want to ask about the concurrent chemoimmunotherapy or adjuvant immunotherapy. So at the moment, it is adjuvant immunotherapy rather than concurrent chemoimmunotherapy. So response assessment CT scan after 2 months show a good treatment response. Patient remained good performance status and came to emergency after 5 months with headache, nausea, and vomiting. So as expected, the MRI brain. So in our, normally the protocol is CT followed by MRI brain. So MRI brain showed a solitary right temporal lobe dural base metastatic deposit with extensive vasogenic edema. Dr. Amna, do you want to add anything else or yeah?
That's the case.
Yeah. So again, I think now this patient first time developed the metastasis. It's very important again to decide in your brain, is that palliation or radical palliation? Because the rest of the CT scan is normal at the moment. Your thoughts on Dr. Kamran, Sumit?
Well, it's a brain met. It is going to be a palliative case, but we, as Dr. Munib already said, we are getting aggressive with our palliative approach, especially with these brain mets and the oligometastatic settings. So stage the patient properly, I would say. But this is a classical case of oligorecurrent disease, and is a perfect case for SABR.
Yeah, I think at the same time, we should not ignore the fact that surgical resection should be one of the primary choice if the surgeons feel comfortable.
Yes, the surgeon should feel comfortable.
Yeah.
Surgeons would always feel comfortable taking it out, but it's not the comfort of the surgeon or the radiation oncologist that we should be thinking about. It should be the results that we are offering the patient. If there is just a 6 weeks advantage of adding surgery to radiation, this is a stage 4 lung cancer. This is not a breast cancer or a prostate cancer. This is a stage 4 lung cancer. And we are talking about months, whether it is 18 months. We are not talking in years.
Yeah.
So no surgery for me. In this case, I would offer SABR to this.
Yeah. Agree. And Dr. Kamran, change in systemic treatment after receiving the ablative dose to metastatic disease, because there are a lot of concept that because there is no disease elsewhere and you have targeted the brain with an ablative
Yes.
dose. So whether to change the systemic treatment at that option?
If the patient is on maintenance immunotherapy, right? In this case,
Yeah.
ideally should get in. I would continue. If there is systemically disease nowhere else except a brain lesion, and you treat the brain lesion with SABR, I will continue my immunotherapy. If I'm giving immunotherapy, if nothing is being
Yeah.
given, I'll watch the patient. I will not add anything right now.
Yeah.
That's my take on it.
My concept is a bit different. There are no studies in lung for that. There have been studies in prostate cancer and in oligometastatic disease elsewhere, and the data increasingly is coming in favor of adding systemic therapy
Yes.
to SABR. We don't have any definitive answer,
Yes.
but my personal predilection is to offer some kind of systemic therapy, be it prostate cancer, lung cancer, or breast cancer. Of course, continue with the same if already something is being offered. If not, do add something.
Yes,
That
and-
would be my predilection.
Yeah.
And prostate,
yes.
and prostate cancer, there's a very, very strong data now. The metastasis-free survival,
Yes.
whenever the PSA goes up, if doubling time is fast, or PSA is going above 0.2, there's very strong data. You add something.
Yeah.
But I don't think so in these therapies. Again, uncharted territory. Some people will do something, some people will not do something. They said just give more time to this patient,
Yeah.
especially if the patient is getting maintenance immunotherapy.
Yeah, and I would just like to add a little bit, like in an era where we have if the patient develop an EGFR mutation, then we have some targeted treatment which target the brain, and along with that, the ALK options also. So
Not be considered progression if patient is on immunotherapy beforehand. Or
It's oligoprogression. It's only progression has to be believe when we change is when there are multiple areas. If one area it's treated, especially in the brain. See, the penetration of immunotherapy in the brain is not good. We know that we can have isolated metastases in the brain. If the peripherally disease is controlled in the lung, liver, viscera are fine, right? Then we are okay with the continuing immunotherapy because of the lack of penetration into the brain. That's one of the reasons. We didn't do EGFR in this patient, right?
we will do that.
Down the road.
So remember, the PDL was negative and ALK was negative at that time. EGFR, the specimen was not available. So patient refused
Very
surgical.
high reason for she's Asian, non-smoker, adenocarcinoma, female. She is a very high risk for EGFR mutation.
Yeah, sure. So patient refused surgical resection as advised by Dr. Samid as well, started on steroids and PPI, and we give stereotactic radiation, 20 gray single fraction. Again, I think to highlight the point is there are a number of fractionation regimen available for the stereotactic depending upon 1, 2, 3, or sometimes 5, depending upon your OAR doses and the volume of the disease. So again, this is an SRS plan which is showing a dose to the single solitary lesion. And so this patient remained well for 2 months. And after 2 months, disease progressed. Because when there was a response assessment MRI brain done at 6 weeks post-treatment, 8 weeks post-treatment, that MRI showed a new lesion in left cerebellar hemisphere. Previously treated lesion showed decrease in size. And CT chest abdomen again showed no progressive disease elsewhere. So this is an MRI brain which showed a small lesion in cerebellum. Again, I think the very important debate at the moment is actually between stereotactic radiation versus whole brain radiation. Again, the other valid option is surgical resection followed by cavity boost, but keeping that in mind that this is a lung primary and has a second metastasis in the brain after treating the first one. So any thoughts, Dr. Sumit?
Continue with SABR. That's
Yeah.
what we intended. We
Yeah.
offered SABR for the same reason.
Yeah.
We'll continue with SABR.
So we did the same, and so basically this was separate another lesion from in the cerebral met. Initially, it was on the right frontoparietal region, so we treated that, and this time we were able to give 24 gray single fraction. So the patient received 24 gray single fraction NGS done because patient now agreed to have further investigation, and that shows EGFR mutation positive, and the mutation that was positive was 19 and 20. So this is time where there was no osimertinib available, so was started on elnotinib 150 milligrams once a day, and patient remained well on TKI, tolerated it well, again presented with shortness of breath, and a CT scan was carried out. So the CT scan showed a scattered multiple pulmonary nodules. Anything else you want to add, Dr. Amna?
No, I think under the arrow, the one,
Yeah.
maybe there's a larger lesion. It's a single slice again. The rest are pretty tiny, but that arrow, I think that's a nice round
Yeah.
one. Yeah.
So again, this patient now developed scattered lung nodules. I think that is the time we need to change the systemic treatment. So Dr. Kamran, this patient was already on elnotinib, and now the progression is development of new nodule.
Well, ideally, the mutation should be checked, the 740M mutation.
790M.
790M mutation. And it's not available again in Pakistan. What I do is, if patient is asymptomatic, sometimes I give them a trial of osimertinib. If patient has been taken, I have a few patients who were on elnotinib when we were using elnotinib. Now we don't
Yes.
use elnotinib, we
That
use
was also
osimertinib
from
right
that, yeah.
now. So a few of those patients have responded well to osimertinib without checking the mutation. I tell them that, if you have a mutation, this drug, 30-40% of patients will acquire this mutation over time, and osimertinib is the drug of choice for these patients. So in this setting, one option is, if the patient is well, not very sick, I can switch her over to osimertinib. But if patient looks sick, then I don't take a chance. I just offer them chemotherapy. If the shortness of breath is getting worse, performance status is going down, then you don't have the window of giving osimertinib and watching these patients. What I do is, then I do chemotherapy, I stabilize them, and then maybe down the road offer them osimertinib at that time.
Yeah, and Dr. Kamran, in the time point now where we are using osimertinib upfront patient as well, so if they progress, do you check any other mutations? Like there are a lot of some people where they have liberty of all the investigation, they look for the rarer mutation. What normally you do?
See, I offer them, but even the drugs are not available.
Yes.
They have developed new mutations. There are second-line drugs available now, which are standard of care, but amivantamab, leseratinib. But the thing is, we don't have those drugs available right now. So
Yeah.
And in this case, if we had the EGFR mutation available at the initial presentation,
right.
would that change anything?
Yes,
Or
yes.
the
The new standard of care is, see, in the Pacific trial, EGFR mutations has to be ruled out. You have to check EGF, ALK, all these mutations. Now, there's a trial in 3C. They have shown that when the patients are EGFR mutated, they were given osimertinib as an adjuvant setting for
Yes,
3 years or
for
2
3
years.
years.
So, yeah, and they did very, very well. There was a very good. So this patient outcome would have changed completely if the patient would have agreed for EGFR. I believe at that time, maybe the trial was not published or not. Recently, these trials
Yes,
got
this was
published.
5-10 years
But
ago.
for Pacific trial, the EGFR mutation, ALK mutation, these have to be ruled out before you offer them immunotherapy. If they are mutated, then you take them. In those times, they were putting them on the EGFR trials. But now the trials have come out for 3C. The EGFR test is positive. You offer them 3 years of osimertinib.
Yeah. So NGS done, and the mutation detected changed to osimertinib. And again, the PDL1 cannot be performed because of the scanty tissue. So patient refused osimertinib due to financial constraint. I agree that option which he agreed for was also something which is expensive. But again, we have a support program available. So that's why we offered her chemoimmunotherapy, which is carboplatin, paclitaxel, atezo, and bev. And so the response assessment CT scan showed a partial response after 6 cycles and remained well for 6 months. Down the lane, the CT scan was carried out, and disease progressed with the development of new pulmonary nodules. And patient now, actually, again, when the patient was in the clinic, the treatment options were discussed again. We all know that it's the patient psyche that they want an oral options rather than the IV options. And now she has actually progressed on immunotherapy. So she thought that her basic initial decision was not right and wanted to try osimertinib at that time. So how frequent you see such situation in your clinics?
Very often, very often. We don't have the luxury to cannot afford the passing of it, cannot afford it to have a vast
Yes.
carbopacly. So yeah, it's very common, but
Yeah.
yeah.
And
So-
is there any difference if patients has brain metastasis in choosing which TKI would you prefer, like osimertinib or erlotinib or anything like that? Will that change as well?
Standard of care is now osimertinib, unless you have certain EGFR which are sensitive to afatinib, or there are some rare mutations also. They are being reported now in EGFR. Once we do the EGFR testing, those rare mutations are also reported, which are not sometimes sensitive to osimertinib. So if you have a whole NGS, you can get a really good detail. But commonest mutations are 19 and L858R mutations, which are both sensitive to osimertinib.
Yeah, and again, afatinib, gefatinib, these are the options which are not readily available in Pakistan. So we don't have a lot to choose between. So patient remained well on TKI for again another 2 months, and then the disease progression was unfortunately developed a multiple brain metastasis, and the primary was also progressing, but patient was asymptomatic and with a good performance status. Here comes again, we know that this time this patient actually had a multiple brain mets. We can't do the SABR. I think the important point, the era where we are living is now, is to forget about the doses which we have already given. Like we have already given a part of brain, the 20 gray, the part of brain, the 24 grain. How often, or what's your experience about whole brain radiation in these patients?
I think we are talking about terminal care now, palliative care only, not terminal, the palliative care only. So I would not count the previous dose or the mean dose to brain from the previous. There is some regeneration in 6 months' time, and lot of time has passed. So just
Yeah.
forget that. When
And
we're
then-
talking about whole brain therapy, you don't really cater for the previous dose.
And I think it's very important at the moment that you develop an attachment with the patients. And when we see these patients with a good performance status and they ask you how much you can offer and how much not, so that is very important decision to discuss with the patient the benefits versus the quality of life she is with, and the time which she has already been passed, like she has a very good 3-4 years with all these treatments. So it's a very informed discussion with the patient in terms of selecting the treatment, best supportive. Nothing is right and wrong. And I think the best supportive care, palliative care, whole brain radiotherapy, everything have the same merits. So again, the other point I think here I want to highlight is, yes, Munib.
Still, one comment on that is still, if we are offering this patient with whole brain radiotherapy, if the patient is eligible, we should offer with hippocampal sparing technique to delay some side effects of the neurocognitive failure.
Yeah,
Thank you.
completely agree, Munib, because yeah, again, it's the liberty and the time of radiation oncologist that's available. And nowadays, I think it's very much commonly used with the rapid arc techniques. We use that. Important question, I resist, because this is something which we experience in our setup, that the radiologists are reporting these patients on RECIST criteria, but I think very important discussion should be the usage of iRECIST, which is different from the RECIST criteria, because we do see pseudo progressions, because as this patient was developing new lesions, but if the patient does not develop new lesions, and if we do CT scan or PET CT, they say it's more in avidity. So how you are dealing in this era?
Well, what I do is if there are not new lesions,
Yeah.
there's just the same lesions,
Yeah.
and patient is completely asymptomatic, doing very well, and there are slight increment in size of those lesions, I treat them as whatever radiology says. I say that this is pseudo progression, and I just watch these patients unless they show new lesions or a very dramatic increase in size of those lesions, or patient getting sick at the same time.
Yes.
Then obviously you cannot say it's pseudo progression.
Yeah.
And while reporting PET, we are becoming cognizant to that. So it's not just about SUVs and small increase in size. I mean, the PET CT resolution may not be that great, but the metabolic component. So when we know there's immunotherapy on board, it is progression if there's a definitive new lesion. Yeah.
I've seen it's good to talk to a radiologist in these cases.
Yes.
is for us.
Tell them this is the history you're giving him.
And that is the time actually we do take these patients to more MDT where the radiologist and everyone is available. And yeah, Dr. Abhita, go ahead.
Yeah, so my question is from Dr. Amna. Dr. Amna, have we adopted iRECIST reporting in our daily practices in terms of lung? Because we are seeing a lot of patients with a very, especially those who have a very high PDL1 score, and within 3 months the report comes that the lesions have increased in size or there is more ground glass. So we, as an oncologist, when the patient clinically is improving but the radiology is going other way around, we also get very confused.
So you're right. Absolutely. We haven't adopted this, but whenever we see progression in lung, we are cognizant. So we are now more careful in our reporting, but I'm sure there are reports that are getting missed out. If we clearly know there's immunotherapy on board, so more so external oncologists actually contact us and do highlight, and it's oftentimes after the report. You reported a progression and this patient is on immunotherapy. The minute we learn that, we're like, oops, sorry, we'll double check. So we are incorporating that into reports. And yeah, I think the point Dr. Kamran says, interaction with the oncologist definitely makes a difference in our understanding.
So just on the same topic, Dr. Kamran, I just have another question for you. So if the patient is clinically improving, but there is radiological progression and we are in that dilemma, whether it could be a pseudo progression, how would you deal that situation? Would you like to continue the same treatment or?
I give benefit of the doubt. Because we don't have many options available, right? And what if this patient is responding and we switch quickly to a DEXI?
Yeah.
You're burning bridges. Once option is changed, you cannot go back to the same option. So when I change my options, I am really, really sure. And most of the time you see overt progression. There are few cases in which we have to decide. In that case, I give benefit of the doubt to the patient. And I keep an very close eye on the patient. Every time the patient comes, I look at his weight, his well-being, how he or she is doing. And within few courses, you will find out that whether this is a true progression or a pseudo progression. If you're looking for it very closely.
Thank you.
And you arrange a restaging CT scan in 6 weeks' time or in 8 weeks' time in those patients you are assuming it's a pseudo progression.
I do it 2 to 3 months.
Yeah.
Yeah.
I think
But
that's very important to give some time if the patient is well. Because again, after the 6 weeks, we have no conclusion with the same dilemma that there is a slight disease increasement. So the patient received whole brain radiotherapy, and because the patient was of a good performance status at that time, and we offered cis-pemi-trexate to the patient. She received 6 cycles, and the performance status now declined to 2. And the restaging CT scan at this time showed 2 tiny hypodensities in segment 8 and 6, which are, I think, visible on the MRI CT scan images. So because this is a real scenario, this patient remained well. Again, you have seen that received 6 cycle because the performance status at the time after whole brain was very good, and the patient was active. So the role of, I would like to discuss, this patient now has a small lesions in liver. So the treatment option, could you go for RFA or stereotactic radiation, or because it's a small lesion, would you go for the maintenance pemetrexate and keep the patient on surveillance? So the treatment option at the moment.
I agree. See, the SABRE guys are involved. One option will be to doing SABRE of those liver lesions. RFA is a good option also. I will not do surgical resection on this patient. From chemotherapy point of view, the patient was getting cisplatin and pemetrexate.
Because she initially had a carbopaclitaxel.
Right.
So this
and she
time
got 4 cycles of cis.
So it's completed 6 cycles,
6 cycles of
and was about
cisplatin.
to start the maintenance pemetrexate.
Right. So, and these are the only 2 areas where disease progressed, the
Yeah.
liver, right?
Yeah.
Yeah. So I'll treat them and I'll continue maintenance pemetrexate.
Yeah.
That's fine.
So after next few weeks, patient performance status declined. She was aware of her disease progression, and unfortunately, the patient passed away. But she is one of the patient who had a long, terrible history. So moving on to a
That's a very, very important point you
Yeah.
raised. That once, if everything is available and you're willing to do all these things, now currently the survival of these patients is changing dramatically. You know, it's a very good case, I believe, which has
Yeah.
shown that one after another. I wish she would have done EGFR earlier on.
Yes.
Things might have changed a lot better for her. You know,
Yes.
she was 58, right? She's a young
Yes,
female.
he was, yeah.
So this is the current modern oncology, medical oncology. These newer drugs have really changed the management for these patients.
Yes, Dr. Irfan.
Excellent case. And this is kind of a very normal case nowadays, where there are lots of options sequentially. I think generally, in principle, I believe that lung cancer is a classical example
Yes.
where you can split the cases into the natural history of somebody getting diagnosed, dying within 12 months, and nothing you can do about it, versus these type of patients who can continue for a long time. And that is where the first question on every slide was palliative or radical.
Yes.
This is where in UK, mainly for insurance patients, when you write palliative and demand saver, they
Yeah.
decline it.
Yes.
So Royal College of Radiologists has come up with a term for radical palliation called palliative. So this is a palliative. So all these patients like this who can continue for several months to some years, one has to keep the mind very much open for palliative approach.
Yes.
Even for the whole brain radiotherapy,
Yes.
when we give whole brain radiotherapy, when we are giving 20 in 5, which is normal, 20 in 5 whole brain, nobody is stopping you to just escalate mildly to 25 in 5 on the GTVs. It is so simple with the modern VMAT solutions. It takes not even one extra drop of sweat. So this is why where 25 in 5 would be considered as wow SRS. So this will be like 25 in 5. That just to enhance the local control. These kind of things are so hard to put into randomized control trials. Nobody will ever do it. So should we not do this for our patients when we know this is safe as a radiation oncologist?
Yes.
Number one. Number two, I think it all depends on these type of patients where the natural history is so long that working so closely with medical oncologists, continuously talking a dialogue
Yeah.
on every scan, discussing about the possibility of intervening with oligoprogressive, with SABR. It's so simple, so easy, so much available, and so less toxic. And even, for example, these type of patients, 2-3 years natural history, 2 lesions progressing, as you showed, 2 lesions on the lung, even 5 lesions in the lung, there's some progression. Continue on osimertinib and go for the SBRT, and this is like a normal approach nowadays.
Yes. Yes.
So this is a classical example where, as a colleague highlighted, that there are not many things available in terms of systemic treatment, but as a radiation oncologist, who we have almost all the tools available in all the major centers, so we can contribute and help prolong the course of the illness when there's a shortage of systemic treatment availability.
Yeah, completely agree. And I think the people who are not treating lung, it's difficult for them to see, or we talk about that these patients are living longer. And we have a couple of patients who have lived for 7 to 10 years. And it's just like, I would say, like a breast cancer now, where you have a lot of mutations available and the options to target them also. So those patients who have a good performance status and who are able to afford and re-NGS is something which I think is very important nowadays in lung cancer, that re-biopsy or do a peripheral NGS and then change the treatment accordingly. But at the same time, I think the main limitation for most of our patient is the cost. Yeah. So let me know how much time we left for this session. Sorry? 9 minutes. Okay. So I quickly go with the last case. So it's a 44 years old male, non-smoker, no comorbidities, presented with cough, 6 months, low-grade fever, no chest pain, hemoptysis, weight loss, no significant past medical history, good performance status. So considering the time is short, I'm just going to do rapidly. So CT scan showed actually a left lower lobe mass with adjacent tiny nodule and significant pleural thickening. Again, the biopsy for this patient was adenocarcinoma, and it was TTF1 positive and synaptophysin negative. So PET scan confirmed the stage, which was T4 and 3 M0 disease. And nowadays, MRI brain is the standard of care. So I think in stage 3 patients, in terms of those patients where the primary is bulky, we normally tend to give chemotherapy. The treatment options in terms of selection of chemotherapy is open. Again, for the pemetrexate, it is slightly expensive than the carboplatin paclitaxel. So normally, what is your preferred treatment options?
Pemetrexate and cisplatin. But now, as I said, 816 has come out, keynote.
Yeah.
So nivolumab,
Yeah.
3 doses. They have shown higher responses, like almost doubling of response rate, and survival data is not out. But and there's no toxicity of performing surgery in these patients after giving them immunotherapy. There was a concern that the surgical resection may become difficult after that.
Yes.
So 3 cycles of chemo with immuno patient can afford it has become the new standard of care now.
Yeah. And we always try to incorporate the radiotherapy in between, but again, sometime because of the extent of shrinkage of the tumor is also very important, that you are able to achieve your esophageal doses, the lung doses. So that is very important to keep that in mind. So patient was started on 6 cispemi and had a good partial response, treated with chemoradiation. And again, the radiation was planned as it is. And so its response assessment CT scan after 2 months show a partial response with decrease in left nodule, and there is no visceral metastasis. So in this patient, actually, it's very interesting in time that he remained well for 10 months, almost a year's time. And then he presented with abdominal pain on and off, and then presented to emergency for within severe abdominal pain, where the imaging was arranged, and imaging shows a pancreatic mass. So again, the primary was responding to the treatment, but this is a new lesion. And it is a soft tissue mass in the paraduodenal peripancreatic area, inseparable from the pancreas, and the biopsy was arranged. So the PET CT was also done to make sure the staging workup is complete, and this is the only site. So the patient developed on the PET CT, the mass was avid, and there was a left cervical node. We did the biopsy that turned out to be reactive. So endoscopic ultrasound guided biopsy of that lesion, and it actually turned to be the poorly differentiated adenocarcinoma TTF1 weak positive, which actually favors the metastasis from the lung. Again, we did all the mutations. This time, the mutation that was picked up was exon 21. Again, I think we have already discussed these options, that the preferred treatment option in this era is osimertinib when it's available. And intent is, again, I think we have discussed a lot, that we should be very clear in mind that this is only a pancreatic mass, soft tissue mass. And the important thing here, which I had want to highlight, is that this patient was symptomatic. So he was presenting and coming to ER multiple times with the severe pain. So we did offer palliative radiation first, 20 grain 5 fraction for symptom control, and followed by that we started the systemic treatment once the pain is stabilized. So the patient was started on elnotinib, and he presented well, remained well for almost 4 years, and on maintenance elnotinib, and then a routine CT scan, because he was on 3 monthly CT scan while on the treatment. So the CT scan actually showed a slight progression, but the performance status at that time was good. He was a young, fit man otherwise. So I think the saber to the pancreatic lesion is still something which is under discussion, difficult to proceed. And again, I think that is an area where to re-radiation in terms of, because this patient already had a pancreatic radiotherapy with a palliative intent, is sometimes difficult to give. And where we have treatment options available, I think it's very important, as this patient has progression on elnotinib. So again, I think we have discussed in the last case as well, there are treatment options available, NGS, rebiopsy, and change the systemic treatment. So any questions? Any comments?
Yes, a small comment. Not a single curative lung cancer case in the whole discussion. That's actually
No,
what
we had one
our
with
patient mix
chemoradiation.
is. I have not done SABR for, it's been 3 years. We started SABR at CMH Lahore. We don't have a single case of stage 1, 2 lung SABR in our setup till date.
Yeah.
That's how lung cancer is. Despite that, we have soldiers coming from all over Pakistan. They have access to healthcare. Despite this fact, we don't have a single stage 1 or 2 lung cancer patient diagnosed in our setup in last 3.5 years.
So in
Highlights
last,
the
yeah.
need for screening programs
Yeah.
as they are in the West now, becoming more and more prevalent. As an imager, those reports are easy for us. So I'm all for screening. Helps the patient, saves money in the long run. So definitely.
And if you ask these patients, most of these patients have already had their ATT
Yeah.
for 3 to 4 months.
Yeah.
I think, in my opinion, well, I mean, first I agree that early lung cancers are not that common. In elderly patients in the West, they present with some vague other symptoms and get routine chest X-ray for something and find a nodule there. And then the lung nodule then get watched and stuff like that. So screening programs are still not established. There's still debate on low-dose CTs or not CTs. But the role of SABR, in my opinion, evolved in lung cancer over the last 10 years, is more frequently used for oligoprogressive, oligometastatic, recurrent, those settings. So primary SBRT for the primary lung cancer is less common than SBRT usages in lung cancer to control the distant disease in the oligo pattern, whether it is brain or outside brain, and to try to prolong the life. Because we all know from the start that stage 3, 4 lung cancer patients are eventually dying.
Yeah.
And this is what I was saying before, that you split them into rapid dyers or the slow ones. And the slow ones, you work so closely with medical oncologists that on every time the patient get follow-up CT scan, you discuss with together as a team to see any opportunity to throw in the SABR as a multimodality approach.
Yeah.
So in this patient, for example, in pancreatic lesion,
Yeah.
I would have given this patient 40, 45 gray in 5 fractions. Very easy to do, no toxicity, really no toxicity for this one. And instead of 20 in 5. So can I do something to shrink the visible disease, which make my medical oncologist colleague very happy? They will be very happy to say partial response, whatever. And then that can help them as well to prolong their currently administered oral simple drug, instead of switching to the second line, third line with limited number of options. Unlike breast cancer, where you have 10 lines of treatment, in lung cancer, there are no 10 lines of treatment.
Yeah.
So this is why I think it is extremely important to continue the dialogue going between the multidisciplinary approach on every follow-up CT scan,
Yeah.
with radiologist, with medical oncologist, with radiation oncologist, and with pathologist to see opportunity for any NGS or somewhere.
Yeah. Thank you. Banana question. Yeah, quick one because we are just short of time.
So my question is to Dr. Kamran. So for a metastatic EGFR mutant lung cancer, once it starts progressing on the EGFR TKIs, if you do a biopsy, how frequently do you come across MET amplification and change in the histology to the small cell lung cancer?
I believe it's less than 5%. It's very rare, less than 1%. It's not very common.
Right.
Not very common. It should be done ideally.
Yeah.
All these things should be done, but that not very common. Not very common.
Okay.
So thank you very much. And thank you very much for the panelists, for the expert discussion and valuable feedback. And thank you very much, everyone.